On Downing here with UW Pharmacy, and he's going to talk to us about just pharmaceutical concerns and things like that. Okay, so let's give him a round of applause.
I have a pretty loud voice, so I'm not going to use the microphone so I don't blast you out. Andrew, thanks for the introduction. So I got my start by teaching dental students. I taught dental pharmacology for 10 years before I came to the UW. And now I'm involved in some dental research projects, and I actually did work with Peter Milgram. I assume you all know him. He and I did some work together in Micronesia and Marshall Islands about 13 years ago or so. So it seems like dentistry keeps coming back. And this program apparently was started by David, who is a friend of mine from his dad and I were good friends in pharmacy school. So for relevant background for me, I was a student here at the University of Washington, undergrad and pharmacy school. And while I was here, I noticed that next week or the following week you have somebody from the Seattle Indian Health Board. So I was one of the 4 people that were brought on to start that clinic up in the early 1970s. So I guess that sort of was my introduction to very high risk populations. I also love the Union Gospel Mission, the perspective over the patient into the window, into the brothel wall that's on the other side of that window. Everyone been there? Yeah, so I do a lot of work, Salvation Army. I've done a lot of work with the Union Gospel Mission. I had the opportunity to start up the Puyallup Tribes Medical Clinic in 1975, where we did everything but dentistry. Those of us, whether you were a pharmacist or a nurse, we actually examined people's mouths and referred them like crazy because it was not a service we had available until we got a dental trailer from the Indian Health Service. Anyway, I really, my entire life has been working with underserved populations. And I don't have all the answers for how we address their unmet needs, but I do love the fact that you have these discussion sessions to talk about it, maybe raise awareness and think about how we might address some answers. The slides that I have, I'm just going to use it rather briefly, but it speaks to work that we've done in the School of Pharmacy to try to address the problem that people who are either illiterate or have low health literacy, have little or no money, how they access services in Seattle. And the slides really speak for themselves. We call it our Where to Turn program. And we find that, and maybe you've seen this too, we have a lot of folks who are really at risk, who really don't want to know a diagnosis. They really don't want to admit that they have something, because from many of their perspective, that as soon as you find out that there's something wrong with you, there is no connection like you and I would make about, well, this is what we can do to help mitigate that. Rather, it's like I'm gonna suffer the rest of my life with this malady. The solutions, the medical solutions, are often not in their minds. And so getting a diagnosis, whether it's dental or internal medicine or whatever, is frequently a real trauma. They often won't share it with you, but I would just argue that when we began this program and started interviewing people on the sidewalks down near the Union Gospel Mission and Salvation Army Adult Rehab Center, that people were really frightened by being aware. For instance, somebody with diabetes, if you gave them that news, they would say, well, my mother and my father had diabetes. They both died in their late 30s from complications of renal failure. And if in fact that's where they're going to, then they're not really a very willing partner in establishing a treatment program for them. Because they don't think in terms of treatment, they just think, well, I guess this is my fate, and having a fateful mindset is not very good at approaching on a day-to-day basis improvement of their medical care. So we work a lot to educate people about what it means to not just have a condition that you need to take some ownership of, but rather than running from it, embracing it and understanding that we're here to help you. You know, there are all kinds of resources out there, but a lot of people don't know where they are, or they can't get there, or they can't read, even if it's maybe their pamphlets given out. We do a lot of verbal instructions on where they can go, because we often see people pretend to read and realize they can't read anything we're giving them. So, you know, so we didn't make this for the dental students, but that was the first item that was on our patients list, was dental care. Especially from the Salvation Army Adult Rehab Center, because these people were now clean and sober, and were beginning to think about how they were going to get out of that program, and they really were looking for a job. And if they didn't have any teeth, or their mouth was an embarrassment to them, then they really couldn't find jobs. And so everyone was looking for dental care. I'm so pleased to see the dental school taking this on. And of course, all these other conditions also. But the thing that we did too was we provide people with pictures. Pictures of what it looks like when you walk into a clinic. And we also, but this might, you know, you might look at this and go, well, this could be a dental clinic, or this is the Pioneer Square Clinic. It's a few years old now, it may have changed a little bit. But you and I would go, well, this is pretty typical, but for most folks, this is the most intimidating thing in their life. To walk into a clinic, and because they're a fish out of water. They don't know why these people are looking at them, and what they're supposed to say and ask and do. It's very stressful. Some people just turn around and walk out. And so messaging that's friendly, that's inviting is critically important. So we also take pictures of the outsides of clinics to hand out to people, because if you give them an address, they may not be able to read it. So, but they will, oh, I know that building, because they're spending a lot of their life on the sidewalk. Let's give them a picture from the sidewalk. And that seems to be very helpful. This photo was, when we showed this to a group of people who were mostly homeless, they all recognized it. They all recognized the building. They knew exactly where it was, but only one person in the group had any idea what was going on inside that building. So I think we all make some assumptions from our perspective. We also mapped out distance to buses and helped people get bus passes, so that if they couldn't walk to the resources, they could take a bus. And those things are available if you know about them. And this really helped. We could go over this map with people and said, okay. Well, in fact, the Salvation Army Adult Rehab Center is right here. And so that's why this map has that basis in the center. But you know, we also learned there were more clinics than we had been aware of when we first did this. And by the way, International District Clinic, Pike Market, they're mostly under the banner of neighbor care clinics now. And from a pharmacy perspective, most of them have a pharmacy and a pharmacist in them, not all of them. But they have been taken over, the pharmacy operations in those clinics have been taken over by, managed by Kelly Ross Pharmacy. Some of you know of them. They've been in town for 150 years. They're in the new polyclinic building downtown, and they also have a compounding center, and they do a lot of work, but they deal a lot with at-risk communities. And they have taken over management of those pharmacies, and the discussions I'm having with them right now are discussions around how do we make pharmacy visits more than just a place where you pick up your medicine. Since I'm on that topic, a couple of colleagues and I wrote a bill last year for the legislature that was passed that recognizes for the first time, Tracy, that pharmacists in Washington State are healthcare providers and they must be compensated for the care they provide. I mean, that's like a big duh, right? I mean, like, I don't know what I've been all these years if I'm not a healthcare provider. But apparently I wasn't one until we passed this bill. But what's unique about it is that pharmacists are the only healthcare provider in the country that I'm aware of that only get paid for selling a product. They don't get paid for any of the clinical care they provide. No health plan in Washington State or any other state, except when there's some sort of waiver or exception to the rule, recognizes and pays pharmacists for any of the care they deliver. So we can't bill for anything other than those pills in the bottle. And since the pills in the bottle are now commodities sold to the, sold by the lowest bidder, mail order and whatnot, their pharmacies do not make money selling medicines anymore. More than 80% of all the pharmacies in this country lose money selling prescriptions. So that is not a source of income for us. And so we have that's the bad news. The good news is that it's energized pharmacists to say, you know what, we are healthcare providers, just like dentistry has said, because you've been on the margins, like pharmacy has, like, oh, we know who a medical provider is, it's a physician, or maybe a nurse practitioner, although nurse practitioners had to fight for it. Dentistry and pharmacy have had to come in kind of from the margins saying, you know what, we're relevant to overall healthcare also. So we are getting there, and I think it's going to lead to pharmacists having the ability to spend more time with more people without worrying about dispensing drugs. They'll be able to bill starting January of this year for clinical care services. We also ask the homeless if they're calling for a prescription refill or a medical appointment, a dental appointment, to understand the processes that might be involved on the phone when they do that. What we found was that most people would hang up, especially on those things where press 1 for English, press 2 for Spanish, press 1 for the, or the number that designates the first name of your dentist or your doctor, and they have no idea because they don't have one, and they hang up, and they don't follow through. So we get really basic. Have a pencil or pen and paper and take notes, and we talk to them about the questions they should ask, and all the other things that are important to them. Typically, if they have a lot of dental problems, they also have a lot of other health problems. More pictures here. We give them. I haven't revamped this. I don't know. Are these still options? Can anybody tell me about dental options? Are these still available? Anybody know? Are they? Do you think so? Okay. There are probably many more. These are only some of the slides we use. But, okay. Millionaire Club. And I'm not sure, is there a dental clinic at the Millionaire? Or is that just a referral service, or I'll have to catch up on that. But certainly the medications that we're, even if pharmacists aren't making money selling medications today, they are powerful drugs, and they're increasingly expensive. My awareness has been raised dramatically what the impact on dental outcomes is with drugs, especially with xerostomia and also drugs that might impair people's memories, balance, ability to concentrate, to follow directions, to remember what you told them. All those things are important. Once again, here's some more places for mental health. There's also, the United Way publishes resources in the community, where they can go to get, hepatitis C screening or some other service. I think it's important for all of us to know what all the resources, not just the ones within our specialty. So as you can see, we've gone to a lot of trouble to try to take a lot of photos and locations. You know, showing the library, because they have access to the internet there primarily. And it's a shelter when they're cold. Public computers that are available. We also talk to them about behaviors in the public library. So here's, you know, as long as you're there, get on Medline to find some evidence-based information, crisis numbers. So if I were to tell somebody who came to me tomorrow where I could go if I was homeless, and I lived in, you know, 2nd and Pine in Seattle, where would I go? Anybody know? What's that? Unigasa. Is that it? Is that where we're, I mean, yeah, that's great. How hard is it to get in? Can somebody walk in? They need an appointment?
You have to be part of the program for UGM.
Okay, so you have to be part of the program. All right, so those are the barriers we started thinking about. Because if I don't know about it, if I came off a bus on 2nd and Pine, and my mouth was swollen up, and I was, you know, and if a pharmacist downtown said, go to the Union Gospel Mission to get your dental care, because my goodness, you're gonna be hospitalized. We need to know what are the barriers for that person to walk in and get that care being taken care of.
They will take emergency patients.
They will take emergency patients in that case. This is
They
what.
wouldn't turn away somebody like that.
They probably wouldn't turn somebody
Or
away,
maybe
yeah.
send them to Harborview.
Harborview probably. Yeah, I know with, it's not easy. These services cost a lot of money to provide. But what I'm trying to get at is what are the linkages between dental and pharmacy that might help us better point these people in the right direction. Equivalent of the entire population of the US walks through a pharmacy door every week. So we have massive numbers of people who come into pharmacies. The question is, do they feel when they walk in like there's somebody there who will help them? Especially if you have ragged clothes, you smell of alcohol. These are the people that probably a pharmacy manager would do their best to have them leave the pharmacy if they're hanging around. What we try to educate our pharmacists to do is actually engage in a conversation with them to find out what services they actually came in for, if they did. I do a lot of work in teen pregnancy prevention in low-income counties in North and South Carolina and downtown Washington, D.C. right now. And we are using pharmacies to provide interventive contraception, initiating contraception, screening for STDs in the pharmacy, and referral services. And so I'm always eager at connecting the dots between professions so that we can appreciate what we can do for each other. Pharmacies, as busy as they are with their head down trying to fill 400 scripts a day to keep the doors open, don't look like they want to help a person. But believe me, the person behind that counter loves doing that more than anything else. So we need to learn how to utilize it better. I think that's it for this, but that's okay. I just want to let you know that we're trying to get connected with the community. What I think I'd like to do, because I know that people have to leave maybe early and such, is maybe just, I don't know what drug questions people might have. I thought I would just leave that, or any questions you might have, even if not related to pharmacotherapy. You asked me a lot of really good questions about
Well,
what
yeah,
resources are available
yeah.
for pharmacists.
I guess the main thing is that we, right now at UGM, or if we go to the 45th Street Homeless Teens Clinic or
Okay.
other clinics, we're sort of repairing damage, you
Yeah.
know, caries, teeth that are lost, loose, you know, from periodontal disease. And some of these are caused by the medications that they take or
Sure.
drugs
Yeah.
that are being not used properly or abused.
Oh, yeah.
So I think education at the front end, if they're getting their prescription meds for psychiatric conditions
Yeah.
or which typically drive them out. that would be helpful, but I can understand that, if there's not enough time, like,
Yeah,
to educate at the front end. It's almost like you don't want the pharmacy team, but it doesn't have to be the pharmacist. It might be a tech or somebody.
it could be, but techs aren't allowed to give them advice about those things, so, by law, so that's a difficult issue. But we are, because of our bill passing, the governor signing it in May, many pharmacies over the next 14 months, because community pharmacies can start billing for clinical services starting January of 2017, hospital pharmacists January of 2016. We are looking at, a lot of pharmacies are working with me to develop a pharmacist question and answer clinical service division that is at arm's length from the dispensing process in a pharmacy. You've seen some of the minute clinic or urgent care clinics that are opening up some pharmacies. Bartell's down here in U Village has a group health relationship. It's a partnership. And so there's a nurse practitioner or a PA in there, and they are seeing patients. We will have pharmacists manning those kind of places, which should make it easier for people to get this kind of information. Now, if they're homeless, one of the things that we'll try to do is work with them to get on some sort of health plan if they can. And Medicaid, and have people on site to get them engaged in that, so we can actually deliver them, some long-term care rather than one-off stuff. Because that doesn't, whether it's dental or blood pressure management, it's not going to do them much good for a one-off visit. So getting people who can enroll people online is not an easy thing to do. It takes resources, but those resources can come back to you when you're able to bill for those things that you might have felt like you had to give away previously. So yeah, there are a lot of potential answers out there. It all depends on whether our professions have the heart to dig in and take care of these folks. I like to think that we all probably do. I don't think most of you decide to go to dental school so you could say no to people. Pharmacy gets accused of doing that all the time because we often have to reject people because prescription somebody wrote isn't covered by their plan. And when they ask how much it costs, if we have to tell them it's $1,300, then that makes it unavailable to them. And right now we have a ton of drugs in pharmacies that are that are $10,000 to $20,000 a month costs. So that just takes a whole number of therapies out of the realm of accessibility. So really prevention then becomes the primary intervention. And and with dental care, fortunately most therapies for dental care are not terribly expensive. Although we have been running out of antibiotics. And a drug like, I don't think it's used in dentistry really too much, but doxycycline used to cost pharmacies about $3 per 100. Last year it was costing pharmacies almost $400 for 100 of those tablets. So sometimes low-cost drugs historically are no longer that way. And I'm sure you've seen on television drug manufacturers being called to the carpet for raising drugs from $15 a pill to $750 a pill, and all that sort of stuff. This is what we're facing in the pharmacy side, trying to manage that so that we can deliver access to care. Anybody have any issues they've run into in their early practices where people couldn't access the medicines they needed, or you thought there were side effects? Anything along those lines? Are most of you involved clinically yet? Some of you are.
Depends what year.
Third year. Depends on the year. Okay. As long as you got me talking, tell people to raise their hands. I'll keep talking. So yeah, thank you. Oh, you wanted me to quiet it down, huh?
So that CEO who raised the drug price,
Yeah.
is that 100 pharmacists like lobby for that to lower drug prices?
Yeah, it kills us. Because chances are the pharmacists, if they had it on their shelves, if they bought it if they had to buy it for that much, can you imagine the carrying costs of having that much? You have to have that much cash in order to carry that drug available. And the problem is insurance plans, I'm sure it's true in dentistry too, are often lag way behind the real costs. And so a pharmacy might bill that, but they're billed at the old price of, whatever it is way down here when the price is up here. And pharmacies, this is one thing that makes them not profitable. They will lose thousands of dollars a day in uncompensated medications they've delivered. Yeah.
Right now, I think, especially in recent years, there's been a big push in dental education to push dental students to see the patient more holistically, not just as a mouth, but as an application of the body. And what I was, I guess, wondering is, what would you recommend? What is it that you would like to see more of in the dental office from a pharmacist?
From our perspective. Okay, thank you. Well, I used to have a pat answer to that. Be open on Fridays. That's sort of the classic one. I've done 40 or 50 continuing education programs for licensed dentists. When I ask them about that, they usually just laugh, well, that'll never happen. So I think that's probably happened, right? I assume. So what we have is no dental services available when people approach us on evenings, weekends, holidays, Fridays, Saturdays, Sundays. So that's where we run into often. We run into that problem.
So it's for opioids or is it?
For anything. Antibiotics, opioids, anything. So because people will come into a pharmacy and ask us to triage them. So we, in my line of work, we have a lot of patients come to us and who have been raped or victims of violence. It's amazing what gets asked in a pharmacy because we're, as far as I know, we're the only profession where you can actually walk up into a room and actually see somebody without an appointment. You can actually wave at them if they'll look up, and so, and we're friendly enough, they ask us everything. So what they ask is, where can I go? I've got this problem. So, having resources available, meeting people where they are on the days they need help, which is 24/7, I guess. That's the biggest one. One of the things that I ran into a lot was dentists who decided to take on somebody's non-dental pain or their blood pressure or other kinds of infections, urinary tract infections, writing prescriptions for those. I know you are, well, we can't do that. Well, I ran into a lot in my practices. I just suggest that that's a good way to shorten your dental career by doing that work. I think the bigger problem, probably when it comes to drugs and dentistry, is probably the pharmacists. I think it comes from that side. Not appreciating and having solutions available for people who have rampant caries due to chronic dry mouth, who have never been told by the pharmacist that this is a problem. This can be a problem. It would also be useful, I think, if a dentist developed, I call them safety net pharmacies, where they provide specialized services depending on the micro community they're practicing in. So if they're near a high school with no school nurse providing reproductive health services, around where your dental practice is, if I were going to open up a dental practice, I would be visiting face-to-face with the local pharmacist, saying, these are the things that I hope your pharmacy stocks because I think it's important to my patients. And that might be, artificial saliva or whatever it may be, gums that won't cause decay and such. Those kind of things where you could stock them in your dental practice, but you may be inclined not to. If you have a place where you could send patients, a pharmacy where you can send patients to, that they're going to get the conversations that need to occur, that's something that would be very useful to your patients. So develop that relationship and make sure they meet your needs. And if they don't send people there.
Yeah, and I think that also raises a good point that at least from what I've seen in clinic, we see a lot of patients, I mean, with what we're trained to do, right, we do like the extra oral exams, or we do like the blood pressure.
Yeah, sure, that's
and all
great.
that. I think we can detect, even though we're not necessarily specialized in the treatment of those conditions, we can still detect them. But one of the barriers that I find is that when we tell the patient, you should probably
See your
go get
doctor
a
by your,
consultation to see your doctor.
yeah,
Most of them put that off. They think
Yeah.
it's hard to get a doctor's appointment, costs a lot of money. Would you say that it would be, are there pharmacies that would be able to would be basically
Yeah.
able to kind of help the patient?
absolutely. They can triage those patients. Absolutely. They know the doctors in the community that are accepting new patients, those that are willing to provide, if you will, pro bono care if they need to, the people who they have a special relationship with. I happen to have a relationship with Planned Parenthood, so if I have a rape victim come into the pharmacy, I can get him into a clinic without any appointment immediately. And we do a lot of other things with them too. By the way, you may not be aware of it, but dentists and pharmacists can create contracts between each other, collaborative drug therapy agreements. So pharmacists in Washington State have been able to prescribe drugs, not just dispense them, since 1979. And we have seen, since the last 10 years, about 8 million patients that we prescribe drugs for them in the state of Washington. So we do chronic pain management, we do diabetes management, asthma management, and such. So a patient may be diagnosed by a medical provider, and then we maybe manage them in long-term basis.
Is that retail or hospital-based?
Retail, community and hospital. So I used to have a collaborative agreement when I had a pharmacy in Federway in Bonnie Lake that did fluoride refills. Signed collaborative agreements with all the dentists in town. And so as the child got older and they need to hire a fluoride dose, we were doing that, then I could make that dosage adjustment and make sure they got the refills without bothering you. And then I just send a note that your patient is adherent and is getting these refills. And we also do immunizations and a lot of other things. But we can collaborate with you if you think there's somebody who you don't want to give a lot of medicine to, or maybe a patient who is maybe cognitively impaired. You could have a collaborative agreement with a pharmacist to help co-manage that patient with you. And then part of that protocol might be getting them back in to see you and helping them get back in to see you. All those things can be written in the protocols. It's not just authority to prescribe it, it's a coordination of care and collaboration that is seldomly used between dentists and pharmacists in this state. And it's a wonderful tool. I'd be happy to come back sometime and talk about how those things work if you'd like. But there are many areas there that I think might start developing a more longitudinal support between the two of us.
I had this idea.
Okay.
Maybe, if pharmacists are healthcare providers, now physicians and other primary care people can apply fluoride varnish.
Yeah.
Maybe every time they come in to get a medication that dries their mouth, following some schedule, you say, time for your fluoride varnish, and the pharmacist actually.
As long as it's within our scope of practice, and I think I would probably try to figure that out for you guys. I mean,
You don't have to have a dentist, you just have the pharmacist do it.
the
'cause
pharmacist,
the
I know,
method
so it would be the
is-
is applying. Now, Peter Milgram had me applying lots of fluoride varnishes in Micronesia, but the rules are sort of off the table when you're that far
They'll have you
away.
applying silver
But-
diamine.
But that's something I've been considering. Now, when we work with dentists in homeless areas, we often do apply fluoride varnishes. Our students and pharmacists are often involved in that process because it's not technically too difficult to do. What's important is access to that care. So that's something we could work on, see whether or not that would be considered within the pharmacist scope of practice to do that. Yes, we are healthcare providers. We're recognized officially by the Attorney General's office now. But our scope of practice, we like to push those boundaries a little bit. And if that's one we could do, then that might be great. So anyway, anything else? I think there are lots of things. I appreciate that kind of question. That's
Well,
really useful.
the clients of UGM, are they getting their meds mostly like from Bartels, or are they going to neighbor care? I mean.
No, they're getting them at Harborview mostly.
Oh, okay.
They get them from the Pioneer Square Clinic pharmacy also, I believe. But Harborview seems to be the primary source that we run into. So we can, educate pharmacists in those locations to the special dental needs that our patients are coming in with. I mean, they're often understaffed and overwhelmed, but if if the awareness is raised, then we certainly can make a greater effort. We need to. Yeah. So I'd rather leave a few minutes early than late. I'll stay up front if you have specific questions of me. I'd be more than happy to talk to you. And I think maybe there's the collaborative agreement thing wasn't something I was going to talk about today, but I think it's an underutilized opportunity that we probably need to talk more about. Yeah. Okay.
You will.
Thank you very much.